treatment failures. And we need to lead with them. We need to make a better diagnosis and a better treatment approaches. For all of you who are familiar with the transplant field, this is a very well-known slide. For those who are not, let me very briefly show you that from the infectious point of view, there is a chronologic order which is very characteristic. And regarding the infections, there is a high risk of bacterial infections in the early post-transplant period, in this period of neutropenia and also of breakage of barriers such as mucosa or skin. There is a higher risk of infections based on both gram-positive and gram-negative bacteria. But this risk remains high at the long term because the humoral immunity actually is defective for several years. And that is the reason why there is a higher risk at the long term of having infections due to encapsulated bacteria. Regarding the virus infections in the early post-transplant period, there is a higher risk of reactivation of herpes simple. And that means that we also need to take this into account for a better prophylaxis, and we need to use acyclovir in the early post-transplant period. After that, we need to monitor CMV and actually be guided through a preemptive or more recently through a prophylactic approach using novel drugs that will be further discussed later on, such as letermovir. And at the long term, there is a higher risk of having reactivation of virus such as varicella zoster, which remains high even at 2 years after transplantation. And finally, regarding fungal infections in the early post-transplant period, there is a higher risk of having infections due to candida, but actually we need to face, and it is more serious, the infection of aspergillus, which again needs to be carefully monitored and prophylactically treated, particularly in those patients at a higher risk of developing infections, such as those who receive steroids because of the diagnosis of graft versus host disease, using, in example, posaconazole. Infections and other complications that we are going to discuss today are related to the failure or the malfunction of the immune system. In this old experiment, the authors were able to actually select a specific T cell who was capable to recognize a peptide derived from a virus. But even this very specific T cell was also able to make allorecognition. This is, was able to identify a foreign major histocompatibility antigen to get activated and induce a cytotoxic effect against against different antigens, foreign antigens. And therefore, this means that potentially any lymphocyte is able to produce this allogeneic recognition. This is a problem in the transplant setting because potentially any lymphocyte is able to behave as Dr. Jekyll and Mr. Hyde, and actually means that we cannot identify a single population of cells which might be responsible for the development of graft versus host disease, but potentially any T cell might be able to induce this allogeneic recognition. And this is based on the fact that the immune response is the degeneracy of the immune response, which is due to the fact that both the T cell receptor and the major histocompatibility complex have a small flexibility that allows them to interact not with just a single peptide, but within a small series of peptides. In the clinical setting, this translates into this situation. T lymphocytes from the donor are able to recognize foreign antigens from normal host tissues, inducing graft versus host disease in the skin, in the gut, or in the liver, but they are also able to recognize foreign antigens in the hematopoietic cells, favoring the development of a graft versus leukemia effect, and therefore the most threatening complication after transplant, but also the greater benefit, which is the graft versus leukemia, are the two faces of the same coin. This is allogeneic recognition, and this is actually the difficulty we have in order to face this complication and to prevent it, but just at the proper time or with the proper strength to favor or maintain this graft versus leukemia effect. So with this background, it is easier to understand the pathophysiology of graft versus host disease, which has been classically divided in three steps. In the first one, the conditioning regimen will induce a damage in normal host tissues, favoring the delivery of pro-inflammatory cytokines. In this time, we are infusing progenitor cells from the donor, but also T cells, which become activated and migrate to secondary lymphoid organs, where these T cells from the donor do interact with antigen-presenting cells from the recipient. This occurs on days 2 to 4 after transplantation, so it is at this time when these potentially alloreactive T cells become fully activated, so that from day 5th and onwards, these allogeneic T cells are able to migrate to the normal host tissues and induce the characteristic damage of graft versus host disease. And therefore, this time frame, days 2 to 4, is key because it's the time when these alloreactive T cells become fully activated. And this activation takes place through the T cell receptor and downstream, where you can find molecules such as calcineurin, which is a key target for some of the immunodepressive drugs that we are using to prevent graft versus host disease. But also the T cell needs a second signal, what we call signal 2, which is downstream co-stimulatory molecules such as CD28. So the more classic approaches to prevent or treat graft versus host disease, but also the new ones actually try to blockade some of these steps. In example, the use of ATG or T cell depletion will basically decrease the number of T cells and therefore might decrease the risk of GvHD. There are more classic approaches, such as the combination of a calcineurin inhibitor, which will be targeting the calcineurin, which is downstream the T cell receptor, together with an antimetabolite, such as methotrexate, and also more novel approaches, which are becoming kind of a standard, such as the use of cyclophosphamide, also acts as an agent which is acting on activated T cells. Actually, this use of post-transplant cyclophosphamide, and Suber will be further discussed later on, but it's becoming a kind of a new standard based on this prospective randomized trial in which the authors demonstrate that the use of this post-transplant cyclophosphamide is related to a better GvHD-free and relapse-free survival, although in this study there were no significant differences in overall survival in both subgroups. There are other approaches. In example, the use of abatacept, which is blocking this co-stimulatory molecule, the CD28, and also in a prospective trial, this drug demonstrated the benefit, decreasing the risk of acute GvHD in patients receiving transplantation from mismatch unrelated donors. And in this retrospective comparison, abatacept compares favorably with the classic approach of a calcineurin inhibitor plus methotrexate, also compared favorably in terms of overall and relapse-free survival with the use of ATG, and displayed similar results as compared with post-transplant cyclophosphamide, both in the match and in the mismatched donor transplant setting. And finally, just a very brief comment on this other study, this other approach for GvHD prophylaxis using cyclosporin, MMF, and sirolimus, because actually in this prospective randomized trial, the authors demonstrated that this combination was able to decrease the risk of acute GvHD, but more importantly, they demonstrated a favorable impact on overall survival. And as far as I know, this is the only prospective randomized trial in which this has been obtained, an impact in overall survival. So with all these approaches, basically that's what we've been able to develop in the last year. The incidence of acute GvHD is decreasing, but also, more importantly, those patients who do develop GvHD have a better outcome, better survival, which basically translates that we are being able to use better approaches to prevent GvHD, but also better approaches for treating GvHD. Regarding chronic GvHD, it will be much discussed later on, so I will just mention that fortunately we are entering in a period in which we will have novel drugs available, and this is really a novelty in this field in which we've been lacking novel approaches, and we have drugs which are targeting different pathways in the pathophysiology of chronic graft versus host disease, such as belumosudil, such as ruxolitinib, or axatilimab. This will be further discussed. And finally, and very briefly, we will also have time to discuss about a spectrum of disorders which are based on damage of endothelial cells. And these cells actually are really very common in our organ. Basically, if you check Wikipedia, it is said that they are as high as a field of football. Team, I don't know what's the experimental design for making this conclusion, but anyway, you can see that we have a lot of endothelial cells all through the body, and of course, they are constantly interacting with the immune cells from the donor. So, not surprisingly, they are also a target of damage after allogeneic transplantation and are also target of this immune response. Not only that, endothelial cells are not just the passive wall of the vessels. They play a very active role from a metabolic point of view and even from an immunologic point of view, and particularly some of these endothelial cells, such as those, the lymphatic endothelial cells, really and very closely are able to interact and control the immune response, in example, inducing the expression of selectins in order to facilitate the stopping of the T lymphocytes and the migration in order to interact with antigens. So a very active role also on the immune and the antigen presentation. So, not surprisingly, they are also a target of damage after transplantation, firstly, due to the conditioning regimen, which will induce damage in these endothelial cells, which in turn might activate neutrophils, producing an increase in some cytokines such as IL-8, but also the production of NETs. If we join this to the next step, which is activation of the complement, then this endothelial damage will perpetuate and will generate microangiopathy. And actually, together with the microangiopathy, today we are able to recognize a whole spectrum of diseases that will also be reviewed during this Meet Expert. This spectrum of diseases will actually or might target any organ, such as kidneys, such as gut, also lung involvement, but also other disorders such as graft versus host disease are also involved, the endothelial cell damage on the pathophysiology of this complication, as well as others such as veno-occlusive disease. So basically, they are a real challenge from a diagnostic point of view, since they do appear at the time when there are other complications ongoing, such as acute graft versus host disease, veno-occlusive disease, and some others. And represent, as I mentioned, also another phase of the allogeneic recognition, both all the microangiopathy, the interstitial pneumonia syndrome, or the engraftment syndrome. The treatment for these approaches being the blockade of the complementum with drugs such as eculizumab. And finally, within this spectrum of diseases, the veno-occlusive disease represents a very particular case of endothelial damage, in this case in the liver, and this disease will also be nicely reviewed later on. In this case, these are the endothelial cells, which when they get altered, basically allow the passive transition of cells from the blood to this space of Disse, and basically they are going to induce a blockade of the outflow at this level, favoring the clinical symptoms which characterize this complication and will be, as I say, discussed later on. So, sorry, here we go. Veno-occlusive disease represents another challenge from the therapeutic point of view, but also from the diagnostic point of view, because there are many other diseases in the early post-transplant period that might appear and are also related to the abnormal function test appearance. And these are all the diseases in which we need to make a differential diagnosis with this complication. In some of them, the pattern of liver function test abnormalities is mainly an increase in transaminases, are those shown in red, but also in others, such as veno-occlusive disease, the pattern is mostly based on cholestasis. So a complex differential diagnosis. And finally, we will also have time to make a short view to the pulmonary complications, which are perhaps the most threatening complications after transplantation. Not only infectious but non-infectious complications will be reviewed during this meeting. So this was a kind of an introduction. I thank all of you for being today with us, both presentially and online, and I have to thank all the collaborators and the ones that allowed us to support this meeting. So with this, thank you very much, and please, the first speaker is going to be Rafael Duarte, which is going to talk about post-transplant infections with a focus on cytomegalovirus. Thank you very much. No,
Phenomenal. Oops. Very good. So, good morning, everyone. I'd like to first congratulate the whole department, the whole Virgen del Rocío Hospital and the Department of Hematology. Jose Antonio in particular, thank you for kindly having me over for this big celebration. 3,000 is a huge number. And for some of you listening to us from other parts of the world where practice is much more concentrated in high sort of critical mass, it might look just regular numbers. This is not regular numbers in Spain. Spain healthcare, including transplantation, is very decentralized, and having the capacity to reach this number shows a long-standing commitment, also Jose Antonio and his predecessors, but also hard work to become a reference center for all these patients. So congratulations on a job well done. And over the next half an hour or so, I've been asked to speak specifically within the infections about CMV. Uh, these are my disclosures, and for the purpose of this talk, really, there's a couple of things to highlight. I've been an investigator and author of the registration trials for letermovir, and that's Merck MSD, and for maribavir, and that's Takeda. So I've worked with the companies in different capacities over the past few years in relation to these studies and to these presentations. I want to give a bit of a perspective, and this is the reality. This is what some of you young students in the room won't ever see, but that's what we've dealt with for decades. It was the ogre, or the troll of transplantation, and you can see pneumonitis on the left-hand side. You can see that cytomegalovirus lesions, and also you can see in Michael Boeck's figure that just resembles what many other departments have seen over the years, that regardless of any other considerations, being at risk for CMV, being CMV positive, just gave you worse performance after transplant by a 10-15% difference, a huge difference. So that was really something that had a threat over patients. And at the same time, these patients over the years will learn to prevent the occurrence of disease, of CMV disease. And nevertheless, they died more, they survived less. Indirect effect, many other effects. So this was the overall spectrum that we had for years. Then, what were the initial strategies? And there were two key things. One of them, curtailment of exposure, and that meant that we learned to do serologies in patients and to make sure that we didn't give CMV post to CMV neg patients that didn't have a risk, and that was part of it, that we screen our blood products, that we knew how the CMV serology of our blood products was. And at the same time, we learned this preemptive therapy. Preempting is, in Spanish, decimos anticipado, but preempting is a beautiful term in English. That preempting is like taking a land as well on behalf of something. So you take sort of like possession control of a situation before it actually happens. And that is the way that we've been acting. We've been monitoring for many years, and this is sort of the conventional management we've had. We've been monitoring patients with antigens, with PCRs, molecular, different tests, and that's changed over the years. But the overall paradigm was this for decades. 4 decades. And we had reactivations that you can see in green, and then we treated those preemptively. And with that, we managed to reduce the number and the amount of disease, CMV disease. But still, overall performance, as you saw in Michael Boyd's curve, continued to be poorer. The one big strategic development we've had recently was the arrival of prophylaxis and its incorporation with the thermovir prophylaxis to the overall structure of management. So let's get a picture of how these worked for us and worked for the patients over the years. Just a couple of slides to our own experience. This is something that Carlos and Miguel, one of our consultants in the team, over there in the room, has been reviewing with us and updating with us over the years. And I'll give you a couple of slides on this. And our results are very similar to what you would see in any other transplant center over the world. Our incidence of cumulative incidence of infection was around 57%, 50, 60%, and that depends on the type of patients you do, whether you do more or less high risk, cord blood transplant, haploidentical transplant. Depends on a number of things, but that's about the rates. And also that has an impact on survival. And you can see that there's still, there was for us a big difference in survival between those that are CMV at risk and reactivate and those that do not. And that is not driven by CMV disease. At the time, with those patients, we had 4 CMV disease cases only. So that's not, those 4 cases are not driving that difference in survival. So still an open space for improvement. And not only that, something that I think is very cool that Carlos saw, that he looked at, and that most registries and most studies don't look at, is recurrency of that infection. Why? Because clinical trials are designed for a primary endpoint, and that might be infection, and then after that, no one cares what happens. And then registries collect first infection, but it's tremendously onerous and difficult to collect subsequent infections. And we had a good idea of how many patients had 1, 2, 3, 4, of the way up to 12, as you can see there in the slide. And then we did this sort of like a homemade cartoonish way of representing this. And this is a little blue square per patient at active treatment for CMV at any day after transplant. And that's the curve that you get. Of course, if you look at the curve, you got a first peak that is fairly early on, and this is what is registered in most of the registries and most of the studies. But you get a second one, and a third one, and a fourth one, and a fifth one, and you get all these recurrent modes, little peaks of CMV reactivation up till 12 in some of our patients, and these represent over 50% of the overall burden of the overall impact of CMV at any time point after allogeneic transplantation. Of course, patients that have these many recurrent episodes are patients that have particular risk factors, and you have there listed GvHD, steroids, some form of transplant. We still do quite a lot of cord blood transplant. About a third of our overall allo practice is cord blood. And then something else that I've summarized here, and is that this had a huge impact on length of hospital stay, measured as the sort of like the key burden readout from our patients. You can see that in the first hospital admission, because our median time to first CMV was day 35, in our first hospital admission, it really extended by about 10 days. If you're reactivating CMV, you're going to be 10 days longer in the hospital with your first admission, and nearly 6 weeks longer during the whole first year. Out of the first year, if you're CMV and you're positive and you reactivate CMV, it's going to be 6 weeks longer of hospital admission. So here came letermovir, a first-in-class terminase complex inhibitor with with pros and cons. Pros in the sense that this target is not expressed, for instance, in human cells. It's fairly safe in a way. At the same time, it doesn't work for other viruses. You still have to do your prophylaxis for herpes simplex, for other herpes viruses beyond herpes 5, which is CMV. But something that was tested, and I'll go fast through this, in a randomized control trial, placebo as a control, 2-to-1 randomization. Clinically significant CMV infection was the primary endpoint, and that makes sense because we all do things differently, and the levels of what we use as a CMV cutoff DNA level to trigger treatment are very different here in Seville from when they are in Puerta de Hierro or in other centers. So we had to compare, with our own real clinical use of the treatment. And of course, it was stratified per center because that was a requirement then. If you're gonna do, you cannot have a center that works in a particular way and then have only placebo. And then it was also stratified by CMV risk. And these were the results. This is the primary finding of a much reduced level of reactivation of clinically significant infection in the thermovir than in the placebo group. Something that when years ago when we used to present all these people were, well, it doesn't really matter because the placebo here, you see, it ends up plateauing, so it doesn't get bad. It gets to a point in which it plateaus, and then, however, letermovir continues to go up. Yeah, it was late because patients were treated till week 14, and these were patients that were not receiving the drug any longer and had GvHD or had complications. Why do they go up here and however it doesn't go up here? It's just the readout. What you put in there is first reactivation. And like in many things in life, once you've had it once, you cannot have a second first time. So those patients that are here were patients that were still reactivating, and they had their seconds and their thirds. They're just not monitoring this curve because this curve is only for first CMV reactivation. So it's a false plateau. It's a plateau for first reactivation, but it's a false plateau in terms of real impact on patients. And affected survival as well. And this is the raw data and the presentation directly from the trial. That's what's at the paper, the New England Journal of Medicine, in December 2017. And this was 6 weeks difference, but it was around 5 to 6% difference. That's huge. That a single intervention specifically directed to preventing CMV changes all-cause mortality by 5-6%. That's huge. That's huge. It's a huge impact. And then that's being confirmed, and this is a different publication a little later. Per Lungman is the first author looking at the impact in mortality. And I think that this is one of this is my last slide on this topic of prophylaxis. But I think it's a beautiful finding because I've showed you before that difference in 10-15% survival that was not related to CMV disease itself, and that we sort of like call on many different things. So other complications, indirect effects, sort of like things that we couldn't explain as an effect of CMV driving that difference in survival. If you look at this here, the two curves in each of the graphs are letermovir versus placebo. And in patients that don't reactivate, letermovir or placebo do the same. This is the same mortality, all-cause mortality that you have anywhere else. However, if you have here in patients receiving patients with reactivation, those patients that reactivated while on prophylaxis with letermovir, which is this curve, had similar survival to the patients that never reactivated. It is the first time that we found a strategy that not only preserves from CMV disease occurring, also overall performance of the patients, even if they reactivate, remains similar to those that never reactivated. It might be because it's later reactivations. They don't reactivate in the first 100 days, and then by the time they reactivate, they're better overall. It might be many reasons, but this is the first time that this was found. And then we got new guidelines. You got new data. You got new things. This stirs up the whole discussion. I'm not going to go into detail. This is SCL 7. This is also 2017, then published in 2019. These guidelines. And we got guidelines, and they help us include the letermovir prophylaxis, include a lot of other things, and review the field. We got new definitions, and along with that, we started working on now that prophylaxis was ready. People and colleagues started working on all these diagnostic categories. I think that the inclusion of strength of diagnosis, the probable, possible, proving, which we had for years in other severe complications, for instance, fungal infections, is something that was necessary as well here in viral infections. And then, as you can see at the bottom, novel definitions for refractory and resistant CMV infection in these patients. And that's pretty much all we got in Spain for many years. and for many years. Why? Because this is the approval of the Ministry of Health for reimbursement of letermovir, which is which includes some of the which limits the reimbursement only and the approval only for high risk patients. That in a way was a bit of the bit fault on the way the whole thing had been named at the study original. I think that Mer has a little bit of something to think about that as well, because when you call a population high risk and another one low risk, you're just giving a chance to whoever wants to control that to say, the low risk is just low risk. Don't you worry. Low risk is still 40% reactivation, so it wasn't low by any means. It's just the way it was. And then they gave us a number of criteria, and this is the criteria that we've been working with and that we've been authorized to prescribe letermovir for since August 2021. And before that, not even with it. And that is 3 years longer than anywhere else. FDA approved November 2017, and EMA approved January 2018. Look at these fast approvals. The paper was published December 6, 2017, and it was approved very quickly. The change in the overall outcome, the change that this brings was so important that the regulatory agencies internationally approved it very quickly. And however, in Spain, it took over 3 years to do this. So I'd like to look at a little bit about that. I'm gonna give you in one slide summarize something that, recent that Carlos has looked at again with the current management with prophylaxis, and then the way we had to look at this was looking at this will hopefully be presented at EBMT this year, right, Carlos? You haven't received any feedback yet. So the impact of letermovir prophylaxis on CMV outcomes, using as a model the definitions of high-risk criteria that the Ministry of Health brought here in Spain. And of course, there's things that you cannot really contemplate, but you can look at the main factors, so all alternative donors, T-cell depletion, all these things, patients that then develop GvHD. First thing, what we saw is that out of our transplant population, around 60% fulfill those criteria. So just by these definitions, we're leaving 40% of patients out of prophylaxis. Of course, that saves money to the government and to the overall thing, but you're leaving a lot of people out of a possibility of having this serious infection, this trough of transplantation control. Letermovir in this population in our hands reduced the rates of infection as we expected, from 57% down to 20%. It's huge difference, huge difference. And not only that, it led to longer time to first CMV reactivation. That was from day 53, once you selected only those, to day plus 108. So clearly, less infection, and infections that occur much later in patients that are already more fit, in patients that are already in a less severe situation. Also, recurrent episodes of CMV infection also reduced. And that makes a big difference for many of these patients, from 50 down to 25, only with primary prophylaxis. And also in terms of clinical burden, you've got data there to see the hospital length of stay was reduced, 39 to 49 days, so 10 days less in those patients in the first admission to hospital in those patients in prophylaxis, and also as well during the first year. CMV disease was similar in both, and that's something also in keeping with what we saw in prior trials. And I leave here sort of like the summary, the benefiting in real world experience derived from the use of letermovir. In reality, it's clear in this group of patients, but it also makes and brings upon us another fact, and is that there's a lot of patients to whom this benefit should also be extended, because otherwise their current rates of infections, of outcomes, and the resource burden remains unchanged, even though we do have a strategy that could change it. This strategy has defined additional things, has other elements, as being longer duration of prophylaxis trials on the way. I'm not going to go into that now. There's other recommendations. I will probably summarize that at the back. So that changed prophylaxis, and we made quite some improvements here. How about treatment? What are the conventional treatments that we've had for CMV? And you got that described: ganciclovir, valganciclovir, the oral formulation, foscarnet, cidofovir, All these are the drugs that we've used over the years, and you got there some of the pros and cons, and the oral administration versus IV administration, and the side effects. That's really what drives the use in most of our patients. Just as a little summary, I put here what you all know: valganciclovir and ganciclovir are far more cytopenic than others, and then than foscarnet, and then foscarnet and cidofovir are far more kidney injury drugs that ganciclovir and ganciclovir are. So we end up deciding what to treat with, and the majority is ganciclovir, valganciclovir, depending on what the profile of our patients are and whether they have any other side effects. That's how we manage it. I'd like to also highlight, because this rates in first treatment. I also would like to highlight some of the data that we got from Carlos's study, and is looking at that toxicity not only in the first line of therapy, but what happens when you use foscarnet or ganciclovir, whatever it is, as second or third lines, because that's something that we do on regular basis, and takes me on to what do we do when first line treatment fails, refractory patients that will build the next spot, and the toxicity increases. Toxicity, neutropenia, renal dysfunction in second line or third line accumulates and is far higher too. This is, again, not very well measured in most studies, but it's something that is a clinical reality that all of us have been facing for a long time. So we need to do better than this. And we need novel therapeutic strategies. And there's a big display here of different things. There's been vaccines, there's cellular therapies, CTLs, cytotoxic lymphocytes. We can discuss in discussion later after the talk about that. But I'd like to focus now on the role of maribavir. Maribavir is a first-in-class drug as well, like letermovir was. UL97 is the target of the drug, and then that's giving a multimodal effect: replication, maturation, and encapsulation, and the egress of the viral capsids. All the traditional anti-CMV drugs before maribavir and before letermovir were primarily DNA polymerase inhibitors. So this is different type of drugs. It doesn't affect the polymerase. This also has an impact because polymerase can continue working, and sometimes you can see DNA, which is what you test, outside, even though there's no viral virions being released from the cell. So it's not affecting replication, it's not affecting infection, but the DNA can still show, and that's something that we see in reality as well in patients. And there's been 2 registration trials, and I'm gonna talk a little bit about both of these studies. The first trial, the 303 trial, was a refractory resistance infections trial. It was an open label trial, and it was a trial in which investigators would just choose what would be the alternative standard investigator-assigned treatment compared to maribavir as described there. There was also a rescue. Treatment was for 8 weeks of duration of treatment, and this is something also important. This is something interesting in the study. I remember when we first were discussing on this trial, most of us were a little concerned about the 8 weeks. We never treated patients with CMV for 8 weeks. Why? Because they wouldn't be able to tolerate it. That's as simple as that. If you give ganciclovir to a patient for 8 weeks, they end up having cytopenias, the majority of them. And then one thinks, okay, so is it wrong to treat for 8 weeks just because we never could? Or would it be a benefit for patients to be treated as long as the drug could be tolerated for that long? So that was the design, and the study gave quite outstanding results. Clearance of CMV by week 8, which is the primary endpoint, was significantly superior in the maribavir group compared to the investigator-assigned therapy. And look at the percentages. The percentages are still not great. It could be better. But something that this shows is that we didn't really know. I mean, what did we do with these patients? They failed 2 weeks of valganciclovir. We were not able, they didn't tolerate them, and then we changed. But the reality is that the levels of response are 1 in 4, 25% in this setting, we were not doing at all well. So we're doing significantly better, at least double, twice as good as we were before with maribavir in this indication. Not only that, this trial included solid organ transplant patients, hematopoietic transplant recipients, different type of transplants, and this forest plot that you see here shows that the benefit from maribavir was across the board in all different subtypes and subgroups of patients in the in the refractory group. Something very important is that all these patients were refractory. That is clinically refractoriness that was in the slide before about the definitions, which is basically after 2 weeks you haven't been able to control CMV. And then we studied CMV resistance in the laboratory. So half of these patients had CMV resistance, and that's also important. I never had personally a gut feeling that nearly half of the patients that I had to change drugs on had an actual CMV resistance mutation that drove that resistance. It was sort of like a clinical context, but this was also important information, and it also worked both in patients with and without the resistance. And I've left out of all the other pieces of information this other finding, which is very relevant and which also ties with what I said before about letermovir prophylaxis reducing long-term the recurrency of events. And that happens here too in a way. This is recurrence and of CMV after successful control with one or the other, with maribavir or with the others. So recurrence in conventional therapy is significantly higher than recurrency with maribavir. If you treat it with your second line X and then you stop treatment because you control the infection, it is more likely to bounce back than if you do the treatment with maribavir. Might that be the length of treatment, 8 weeks, compared to whatever you treat with Foscardi? It might be a different thing, but clearly it does work as well to sort of prevent that recurrency after transplant. And I leave you, this is the last slide on this refractory study, giving you a profile of the safety, safe drug. It has very clear dysgeusia and alterations of taste as the main side effect, but neutropenia, acute kidney failure, all these things never don't happen. They happen in the valganciclovir and foscarnet group of patients. And this is the 302 trial. This is the first line treatment with maribavir of CMV infection. It was a randomized 1-to-1 double-blind, perfect design, one-on-one maribavir versus valganciclovir. The one thing that I probably have to highlight here, and it's probably one of the limitations of the study, is that in order to randomize in a double-blind fashion to a drug like valganciclovir, which causes neutropenia, causes cytopenias, of course, like in all trials, but in this one in particular, you have to aim for an inclusion-exclusion criteria that leaves out anybody at risk of cytopenias. So you have to have better levels of neutrophils, platelets, and red blood cells than your average patient. So it's a very, very selected population. If you call probably a population in whom you might not really need the new drug as such. But that also drove the final results of the study. 547 patients randomized, 12 weeks follow-up. And as you can see, at the time, week 8 of the primary endpoint, the results were not different, really. The results were the same. If we look, this is week 8, and then week 12, and 16, and 20. In blue, maribavir, and in pink, valganciclovir, there's no big difference. So clearly, it's not better. As a matter of fact, at the time of the primary endpoint, that was this one, it did not met non-inferiority. So in reality, the drug was not approved. It's a negative trial, and that we have to say. But at the same time, it's a negative trial that leaves a lot of open space, because I wouldn't want to use a new drug like this in every single patient, for every single patient that can tolerate valganciclovir. Valganciclovir is oral, is good, goes home, that's it. But I would want to use this precisely in the patients in whom it has not been tested. in my patients with borderline cytopenias, in those patients that you're ready to send home, but they have 25, 23,000 platelets, and at the same time reactivate CMV and say, I gave this guy now valganciclovir, we send him home, and I know I'm going to be transfusing him and bringing him as an inpatient again in just a few days. Those are the patients that we've used, and those have never been treated. And after a negative trial, it's unlikely that a big new trial to addressing these patients is going to be done. So I'll finish, and these are my last 4 slides, with a bit of a summary of all these changes, new data, new guidelines. You gotta publish papers, you gotta get the groups running, you gotta get people together on the table, and now we have new guidelines that I think are useful in the sense that they incorporate a lot of the new stuff, and some of it you'll see, and also new guidelines. This is not the final version. This is on that SCL website that you see there is open access for you all. So anyone that wants more details can go and see this in detail. But also, like all guidelines is you can put 20, 30 hematologists, virologists, microbiologists in a room, and after so many hours, you just get your neurons crossed. I think it's difficult to know. So let's excuse some of the typos, let's excuse some of the things, but there's things that I like to comment that I think are very useful, and things that I don't fully understand. The Rafa de la Cámara, who's one of the leaders internationally and nationally in this world, and who's being past infectious diseases working party chair of the EBMT, and as part of that also at the SCL guidelines, says that the paper is already in circulation for review, and that is going to be published hopefully very, very soon. But this is the data that we currently have. I'd like to share it with you. There's a lot of recommendations in things like monitoring, and a lot of stuff there has not changed. Weekly monitoring the first 100 days, and then you can use plasma, you can use blood, this and that. All that has not changed from SCL7. However, I've read this, I don't know how many times. I put this in this purple color. This is Seville. Purple is Easter. This is penitence. So I put this consideration down to penitence and to be thought twice. And then I don't know how we'll interpret this. But in este púrpura nazareno, in this color, I put this somewhere because it says something that I don't honestly still understand. Less frequent monitoring than once weekly can be considered, especially in CMV donor recipient negative. So I mean, a lot of this, when you are in this group, you realize there's a lot of pressure from different teams. So obviously, the microbiologist, the virologist that has a lab full of technicians doing tests, last thing they want is that you say, you have to do something different. You're not doing this, because what the hell do they do with all the technicians? No? What do they do with all these people? So there's pressures in all these things. But honestly, monitoring CMV neg is not less frequently. We don't monitor. I wouldn't monitor CMV neg. And not because you cannot go get the odd positive result in the CMV test. It's because that positive result, by definition, is going to be a false positive result. The thing that drives performance of any test is not only sensitivity and specificity of the test, but the pre-test probability of the test being positive. If we do always put this example of many other things, it's something that we showed in the field of fungal infections. If you have here a urine pregnancy test, sensitivity, specificity, well-defined, but then you pass the test to all the guys, to Simon, Jose Antonio, and I, and then we take the test, and then it's going to be positive. One of them is going to end up being positive. But the chance that we're pregnant, independently of what it might seem, the chance that we're pregnant are so small that any positive test is going to be a false positive. And that is exactly the same thing we're doing here. CMV, negative donor, negative recipient, the drug is being controlled. They just test it just in case. What in case? What in case? It's not less frequent. It's useless. So anyway, penitence color, purple color for this recommendation. Then, recommendations that I think are very good. Extended prophylaxis should be considered. And then we're talking about at least 200 days, and this is something that's recognized. That's something that we do. That's something that I think that overall in high-risk patients with corticosteroids, with GvHD, we extend to 200, and even longer than 200 can be considered in some of these patients. So that's already is good that is collected there. Also, it recognizes and embraces the thermoviral bleed. This thing we said, this thing does not block DNA polymerase. So, it's going to be producing DNA here and there. So you can get CMV positive PCRs, and still that doesn't mean that there's an active reactivation occurring. So, stay calm, continue with prophylaxis, and don't change things too abruptly. And that's something that we all learn to do. Before we would treat everything with the lowest, faintest positive result, and now we know how to wait with this. And then after discontinuation of prophylaxis, secondary prophylaxis with letermovir can be considered. And that's something that is out of the label, and this is one of the beauties of talking here with in a meeting that Jose Antonio organizes, because we're free to say whatever the hell we want. So secondary prophylaxis should be considered in many of these patients in whom the risk remains high. Maribavir is effective in treatment of infection and disease in refractory and resistant infection. And that's changed. That's changed the way we manage these patients. It is important to note that because of brain barrier issues, CNS and I is not the target, but for the vast majority of our patients, this is what we would do. Uh, Resistance is the main driver, and that's where we should start, regardless of. Refractory is where we should start, regardless of resistance. But we should do the genotyping, and we do. What is the problem? That in most places we don't have readily available results that can help us make decisions based on that. We normally send this to some reference lab and we get the results a couple of weeks later, by which time we've already changed, we have already treated, and that is taken into recommendations. And people say, you got a genotype, at the same time they say, you got to change treatments and initiate treatment upon refractoriness without waiting for viral resistance. And then in case of refractory, exactly, without waiting for resistance. And then I finished, there you go. Something that I think is also quite brave and quite nice, because the Aurora 302 trial is a negative trial, and nevertheless, recommendations from the committee, I think that they're very brave on that, is that in first line, maribavir can also be considered in patients with neutropenia or with renal function impairment that you don't see appropriate for standard treatment with the standard drugs. That's something that is not in the label. That is something that is not the population in whom it showed to be negative. It's not that population. It's the population precisely with the side effects. And that's something that I think is good that the slides summarize. And then I'm going to finish with this. Then they come together, all of us hematologists, and get together in a room, and then you decide to do an algorithm. And then, the whole purpose of a bloody algorithm is making people's life easier. If an algorithm doesn't turn something complex into something in which you clearly see, okay, this is how I have to proceed, then it's useless. And then there's things in this algorithm, of course, brainy things, of course, looking into details, and then refractory CMV without known resistant mutations, and then you might optimize valganciclovir. No. Refractory CMV, you use the drug that does best at this. And right now, that is the maribavir. And then looking at different mutations, that might be good. And then you have that, but you normally have that several weeks later. And then you sort of navigate all that in something that, to me, I still spend time on this, and I still don't fully understand it. So I'm making it also purple. All this penitence for this algorithm, and they have to rethink and make it a bit simple for simple-minded hematologists like myself that need to have very clear instructions on what to do with patients. So I hope to have covered most of what I wanted to cover on this. It's been 36 minutes now. So I think that CMV has changed so much, and it's something that before, the on-calls of the personal transplant team, often every week, very often you have patients with new reactivation that you have to talk to the virology guy, you have to bring in, you have to call to say you got to come tomorrow. This doesn't happen any longer. We just don't do this any longer. It's just rare now. It's very infrequent. And not only that, those that do reactivate, we have better drugs to treat, and they have less cumbersome recurrency of infection. So I think that, of course, we need to abide by the recommendations, apart from the purple recommendations. We have to abide by the labels of the drugs, but at the same time, I think that there's enough evidence already out there to do a significantly better management of all these patients and a significant less complex outcome of our patients out of that old troll of transplantation that we managed to domesticate in recent years. So thank you very much. Questions now or later? Now.
We have now
Okay.
time for questions now,
Okay.
and later on, depending on how good we are with the schedule, we will have some more time for discussion. So congratulations with your green talk, not purple at all. So are there any questions from the audience? Okay, I will start. I mean, I'm sure you don't do that, but guess that you could be able to use letermovir on whatever indication, irrespective of the approval of the national agency. That you don't do, I'm sure. There will be any subset of patients that you might consider not to use it?
It's, I mean, that's it's a, it is a good question because it's out there, no? It's out there. The answer is I'd use it in every single R positive, in every single positive CMV receptor, in everyone. Why? Because I would need a trial against it that proves me wrong. So we're very accustomed to waiting for to designing trials, and then the trials give us results, and then based on those results we get formal approvals, and then that's what we are guided by. We don't use it outside those limits of those trials. However, something that happens in science is that you get a trial that tells you all CMV positive recipients that we put in this trial, whether or not they had a positive CMV result before, whether or not this and that, all those as a block get benefit from this drug. And however, we sit down with our virologist and then we get smart and say, you know, but this subgroup, I'm going to do this interferon gamma test. And if my interferon gamma test tells me this, then I'm going to withhold it. Sorry. We wouldn't be able to give a drug to a patient based on some smart discussion if we don't have a phase 3 registration trial that tells you to do it. And if we want to explore that, then we do a study. What we cannot do is go from something that is fully approved into something which I'm going to get smart not to give the drug that is approved and that has shown benefit in those patients. So my answer is no, and I understand that there's strategies that are complementary, and I understand that there's a lot of interest in immune modulation and control of CMV that might help. I think they probably help us better, and that's also in the SL studies to see how long, at which point I stop, no? But I don't think that I would change I would leave everyone out of the CMV seropositive recipients with a trial that disproves that that's of benefit for that patient.
So clear answer. Maybe someone from the drug agency will make you to have some penitence.
No,
Put you in purple.
Absolutely.
Other
But
comments,
I
questions?
remember I remember in one of these meetings at SCL, the fungal, we were discussing about the issue of all these diagnostic tests and how people in prophylaxis should not have galactomannan done, as a surveillance. No, and that was something. And there was this renowned Italian colleague, a big figure in the thing, that after all the discussions, they know this got to be a D. This has got to be a D recommendation. This is what came out of the European group, and said, Rafa, yeah, but I got a lab full of students and full of technicians. What do I do with all them? That's what he said. And it's true. All these, at the end of the day, many times these decisions are like that. So I'm sure that I've got purple all over me in some places. That's okay. That's fine.
For how long are you maintaining the monitoring of patients who have received letermovir?
So yeah, so that's we haven't then changed that dramatically in the sense that that's another thing that I think is the trial. There was at the beginning of the prophylaxis with the letermovir, there was this sort of dichotomy. So do we do preemptive or do we do prophylaxis. Like you have to be on a team. Humans work like this. You're on the preemptive team or in the prophylaxis team, and there's no such teams. The trial in the prophylaxis arm and in the non-prophylaxis arm, because it was blinded, did exactly the same monitoring, which was the traditional monitoring that we were doing, the one that is continues to be recommended. So once weekly for the first 100 days, and then from there, depending on risk, and then depending on whether or not there's been reactivations before, and depending on now whether they have GvHD, that kind of thing. And we continue to do the same thing. We continue to do the same thing, right, Carlos, Ana? Or do you guys do whatever you want?
Thanks, Rafa, for this nice talk. My question is, in general, from the time we started using letermovir in prophylaxis, we understood that we had to start prophylaxis when we knew that copies were undetectable at patients. So what would you do with these patients that have a small amount of copies detectable before starting prophylaxis?
That is a great question, and that's something that we discuss at the department quite often. The trial, the way it was designed, is that you had a central lab reference. So you screen patients, and then on the day that you were going to start with the drug, you sent a sample. Just to see how that was. But you started, were randomized, and patients would start having letermovir or placebo. And then those samples from central lab would eventually come back saying it was positive or it was negative. No, so the trial showed that those in whom those samples were positive did just as well as the rest. So it didn't matter. It wouldn't have changed results knowing that they were positive. And again, once we had that evidence, of course, we know that in vitro, letermovir in vitro, the number of passages you need to generate resistance are very short. Compared to DNA polymerase inhibitor, these are drugs that generate resistance quite fast in vitro. But that does not have a clinical repercussion. So I think that the new guidelines also say that, having gone into all this is like one of the green things of the new guidelines that recommends starting as soon as possible, and there's not real anything against having that done. They tell you to do a pre-test. We've done over the years sometimes waited to see whether it was a one-off small positive and then wait to see, because the range of time when you can start thermography is up to day 28. So, but then with some of them, we've ended up missing the gap. And now I think that what we're going to do is what we did in the trial, is going regardless of what the CMB was, because those patients also benefited in the trial, even though it was a smaller group. It was 70 odd patients, something like that. But it was a smaller group, but the benefit is just the same. Dr. Piñana. Hello, José Luis.
It's no. Hello, Rafa. Thank you for this magnific talk. I have one comment and one question. The comment is that we should be a little bit careful with recipients seronegative in cases of lymphoproliferative disorders when they receive a lot of cycles of Rituxan, for example. That's why
or in
it's
myeloma. I
important.
understand. Autologous myeloma, there are autologous that then end up having myeloma and end up having an autologous trauma. With the current treatment, some of these patients can have CMV reactivation.
Yeah.
But my criticism was as a group for a standard surveillance, because then it's very difficult to get a real predictive value of that odd result. But yeah, I understand.
Yeah, no, my message is it is important to have the serologies at the time of diagnosis of the hematological malignancies, in case that if they receive a lot of monoclonal antibodies or several lines of therapy, CMV status can be false negative.
Absolutely.
The second question for you is, in case that you see breakthrough CMV anemia during a thermoid prophylaxis, and you treat with common antivirals, and you reach a negative PCR value, that means the virus has cleared. Did you start again letermovir as secondary prophylaxis, or you think this is a failure of letermovir?
That is a great question, and it's one of the gray areas gray areas where there's several alternatives of things you can do. You can do secondary prophylaxis with letermovir, and there's experience of that. The experience of that on patients that having not had primary, had an infection, and then you give letermovir as secondary. But there's also experience in centers using primary reactivation and then put it again because they're still on corticosteroids as secondary. And even though these are not formal, well-established studies to show better or worse, results continue to be reasonable. So I understand this philosophically, biologically, one thinks, okay, this being a failure first, you know, is the same CMV or is a mutated CMV, or how the new CMV is going to be resistant to this. So I understand that that's a question, but that's been done. There's an alternative, and is that right now we're using treatment, and it's primarily in patients that take longer to control. If you're treating with a refractory CMV with maribavir, you can treat 8 weeks, or you can prolong that too. We know that primary prophylaxis with letermovir have reduced the number of those recurrences, and we know that the rescue therapy of refractory patients with maribavir has also reduced those recurrences afterwards. So it's going to depend on whether it's a first or second, because if it's a first reactivation, then you cannot really come back with maribavir there, and it's going to depend on other factors. I still think that for patients at high risk, first reactivation, respond well to valganciclovir. After that, probably letermovir secondary prophylaxis would be the thing I would do choice. Even assuming that I'm not going to have results on actual resistance, because I don't know whether you guys get them in Valencia. We take us longer to get meaningful results there, and I think that in that situation it might be that. And then maybe if we're talking about refractory disease, and then we treat it with maribavir, and you control it with maribavir, and then the risk continues, maybe at that point I might be more prone towards sustaining a prolonged treatment till the risk goes away. That could be the way to do all of that.
Okay, thank you very much, Rafa.
You,
we
guys.
keep on going. Rafa will be available for more questions at the coffee break and in the lunchtime. And our next speaker is Sinaida Perik from Zagreb. She is currently leading the group of GvHD at the ABMT. So it is our pleasure to have you today with us. And she will be discussing mostly on acute GvHD in this talk, and the next one she will be mostly focused on chronic GvHD. Welcome.
Hear me? Yes, so thank you so much. It's such a great honor to be at this celebration of 3,000 of transplants. I feel very close to that because actually I come from Zagreb, where we just recently celebrated 40 years of transplant. So I suppose it is something about similar. And then I moved to Rijeka, where I'm establishing a new transplant unit. So I hope to give you back the invitation in some time in the future. So it's a great pleasure to be here. And my talk is a bit rather clinical, so I hope it will be good for discussion. And I have separated it into two parts, the acute GvHD, and later on we'll talk about chronic. So the first part is somehow basics or a general approach. And the second part is something that we are all aiming to, and that is an individualized approach and the unmet need, which is, of course, the steroid refractory acute GvHD still. So we are talking about acute GvHD because incidences of it still remain consistent, although we are, let's say, managing it better and we have less grade 3 and 4 acute GvHD. We have feared that use of peripheral bloods and haploidentical will increase the rates of acute GvHD. However, we have randomized data that are showing the opposite, or as shown here on the left, as it comes to acute, they're higher incidences of chronic GvHD with peripheral blood stem cells. Also, in the large registry studies, we have seen that even in comparison to matched sibling, haplo does not always increase the incidence of acute GvHD, and it can even decrease the rates of chronic. So this is reassuring. But still, we haven't moved too much from what we do in the first line. So high-dose corticosteroids are still standard therapy for acute GvHD, and we want to move towards a personalized approach, because in this way of treating the patient, some patients are probably being overtreated and the other ones are being undertreated. This is why we need a personalized approach. We are lucky to have a drug approved in the steroid refractory setting today, which is ruxolitinib. However, we still have some patients who are refractory to ruxolitinib. And we have learned a lot about pathophysiology of acute GvHD, and today we recognize that it's not only about immunosuppression, but it is also about dysbiosis and tissue repair, and this is, I believe, a place where we can work on the most in the future. I start with some general things that you all know, but I always find it useful to remember what are the typical frequencies of presentations of GvHD, because I'm not going to focus on skin, as it is when it presents as a sole presentation, well, it's usually managed as an outpatient, and I would say that when it presents with other types of acute GvHD, and that's mostly the case, it's like a marker or let's say a confirmation of acute GvHD. Even the expert agrees that biopsies of skin are not always performed, although we do say that they should be performed. But let's say maybe 60% of those skin GvHD are confirmed, and as I said, usually use it as a confirmation of acute GvHD in general. And what I find interesting is those presentation of liver GvHD, which is actually most commonly with gut and skin, and more rarely with only with skin, and only liver presentation is actually very, very rare, and this is what I'm going to mention a little bit later. So I will focus on gastrointestinal acute GvHD because, of course, this is something that we difficultly manage in an outpatient setting, and we have more difficulties in diagnosis and treatment in general. For the case of discussion, I've showed some typical and actually real-life case scenarios, and I will just continue my case on what Rafa has told us before. So this is a classical patient, a high-risk AML, who had an unrelated donor transplant, and everything went well until day 80 when she got an acute intestinal GvHD or diarrhea, to be honest. And then we did the rectoscopy, which confirmed GvHD. At that time, PCR was for CME was negative, but when we initiated steroids, he first responded, and approximately 3 weeks later, diarrhea reoccurred. With a little decrease of immunosuppressive. So we, at that point, actually redone the rectoscopy, which, to be honest, we don't do always when we have, let's say, worsening of diarrhea, but we did. And we were considering ECP, but at that point, we got the confirmation that it's actually CMV colitis. So just to remind you actually, and to highlight the fact that, and we talked about CMV reactivation, actually in CMV colitis, it is not the case that we always have the PCR CMV in blood negative, and the right confirmation is going to be the histology. Should we then perform lower endoscopy always in patients who have diarrhea? Well, knowing the fact that differential diagnosis of diarrhea is pretty much narrow, and that we are going to usually have, let's say, mucositis resolved by the day 20, so this does not really interfere with our differential diagnosis. infection is, let's say, easily excluded because, well, we do the microbiology tests promptly, and usually in GvHD, the volumes of diarrhea are higher as well as in comparison with toxicity of drugs. But okay, histological confirmation will do this differential diagnosis if needed. And of course, CMV is becoming less important due to the latermory prophylaxis. On the other hand, we know when we do the histology, the GvHD presents in a patchy way, so it really depends, are we going to get the histology right or from the right place? And this clinical and histologic and endoscopic, what you see in endoscopy, actually poorly correlate when estimated in lower gut GvHD onset. And when looked prospectively and retrospectively, we do not always get the histological confirmation, and we don't wait it at all because we start the treatment before we get it. So 50 to 80% confirmation happens in retrospective studies. So can we do something else beside endoscopy and histology? We know that classical imaging is not useful. CT, MR, ultrasound, that is actually not recommended because it's not specific and sensitive enough. But there are some interesting data which I have found on PET-CT, which of course we do not use normally when diagnosing GvHD, but actually has a very high sensitivity and specificity, even if we did not expect it, and it can actually early detect GvHD changes. So this is something to maybe remember, as well as endoscopic endomicroscopy. So doing the microscopy while doing the endoscopy at the same time. So having the real life, let's say, real-time diagnosis, which is extremely sensitive, extremely specific, and can be used for early detection, but of course needs very skillful and trained physicians, and is not available in routine, but might be something to be interesting to confirm in some of the prospective studies, of course. Is there any useful biomarker? Well, I will talk about biomarkers a bit later on, but we all know that biomarkers are not readily available in everyday life, as at least the traditional, the magic biomarkers. So is there any other thing that we use in everyday life but can be used as a biomarker? Well, actually, what we always do is evaluate the albumin levels in patients with lower gut, well, in all patients with GvHD and in all transplant patients. And it has been actually shown that gut protein loss actually precedes symptoms. And if you check the proteins along the allogeneic transplant, actually at the start of acute GvHD, a drop by 0.5 can actually predict the development of grade 3 to 4 acute GvHD, which is interesting. And gut protein loss precedes symptoms because there is a loss through mucosal tight junctions and not weeping of serum from ulcerated mucosa. There's also some interesting data on fecal calprotectin, where actually this is significantly higher in GI GvHD than in non-gut GvHD or GI infections. So there may be place for some more readily usable biomarkers in GvHD as well. So I would maybe answer my question, do we need lower endoscopy? And you can say if you agree or not, that probably if you have the high probability of lower gut GvHD, skin GvHD that is present, the risk of CMV is low, and screening for gut infection is negative. It is not crucial to start the treatment. You will start the treatment anyway. But in any time there is failure of initial treatment, you need to do the rectoscopy again, because you are not sure that it's not CMV, even if there is no CMV reactivation. So as I showed in the first case, the CMV colitis needs an endoscopy proof. So any kind of failure of treatment should, I think, require endoscopy. And there are some other methods that can be, let's say, rethinked in the future, or something to be used when you need them. My second case is a continuation, not the continuation of the previous, but of GvHD, but of the upper GI GvHD, because I believe this is a typical older patients transplanted. I think they always or very frequently actually complain of anorexia, of not eating, of loss of weight. And this is a patient who developed this late nausea from the day 35. And at the end, we said, okay, fine, let's do the endoscopy, which we did. And histology actually came negative, but there was a mucosal edema seen endoscopically. So again, a discrepancy between endoscopy and histology. But as symptoms persisted, treatment was initiated, and I will go back to upper GI treatment because we know that non-absorbable steroids can help here, but in this way his symptoms resolved. And my point here is then in upper gut GvHD, histology is often negative, so even more than actually in lower GI GvHD. And here the differential diagnosis is actually even wider. It should not be after day 25, which we usually, let's say, a bit maybe neglect for some time, but after day 25 should not be related to conditioning, and we should not neglect it if it goes on. And you can see that histology is positive in upper endoscopy even less frequently than in low endoscopy, so 27 to 80% in retrospective studies. There's some also another interesting tries, let's say, of diagnosing GvHD in another way. We are today very well aware of the role of microbiota, and there are some interesting, let's say, things that can be also done, but of course are not are in everyday use. So breath analysis, because macroorganisms produce volatile metabolites, which in GvHD can alter to volatile organic compounds, and this has been actually shown in breath analysis in patients with GI GvHD. So I would conclude that upper endoscopy should be considered in patients with persistent satiety, nausea, vomiting, or anorexia after day 25. There are some alternative methods, but what is even more, let's say, important than histology itself is endoscopic finding, which can be, let's say, more impressive and can confirm the diagnosis, though histology is frequently negative. And one other thing is that if you have a patient not with upper GI GvHD but diarrhea, and you do a lower and upper endoscopy at the same time, you actually increase the positivity of histology to over 90% prospectively, meaning that probably doing both upper and lower endoscopy would make the confirmation of gut GvHD much, much higher. When it comes to, again, lower GI GvHD and its treatment, I wanted to show a patient who is typical because it's a lower risk GI GvHD. So patients who develop GvHD after we stop immunosuppression, as you all know, these are the patients that we usually treat more easily, and they respond to immunosuppression more easily. And this is a patient like this who developed nausea and diarrhea, but not very huge volumes, with no abdominal pain, had the confirmation, but had stable albumin levels. And this patient was a perfect candidate to initiate lower dosages of steroids with non-absorbable steroids. But after 5 days, this symptoms did not resolve, with liver enzymes that increased, and actually patient was admitted and his IV steroids were increased. And here actually I want to make a point that not all that of course gut GvHD patients are the same. Today we know which facts increase the risk of mortality and which patients are of lower risk, and we also know that at least 2 minimalist approach were shown effective in randomized trial in those low risk patients. And these are the milligram per kilo prednisone together with the oral steroids. which in comparison to placebo worked better. So this is the, I would say, the one standard approach. I don't know if gastroenterologists always ask you that, but they always ask me why peroral if you are giving the intravenous, but it really does work. And also even lower dosages might be effective. But what is actually important that that you will not, let's say, compromise the response to a higher dose if you need it, because actually best responses to secondary therapy are in patients whose initial therapy was lower. So we don't need to be worried if you have to start with lower doses of prednisone. When it comes to upper gut GvHD and treatment, again, topical therapy has been shown to work. So topical therapy only without systemic corticosteroids. And this is what we recommend for upper gut GvHD today. Also, well, actually, this oral steroids show to work even in the lower gut GvHD, but this takes long, so 1 to 3 weeks, and we usually do not have such a long time to wait. But for upper gut GvHD, it works well, and it's worth to try it. And also, I don't know what is your practice, but I have worked in a center where it has been for ages, gut rest was very much forced. And as a young physician, I was always wondering, but how can they recover if they don't eat? But it was, of course, always, and it is true because today we know that enterocytes do not recover without food. Introducing total parenteral nutrition is great for the doctors because it decreases the volume of that diarrhea. So it seems that treatment is working. But today we have so much proof that it negatively impacts the enterocyte recovery, the dysbiosis, that actually even we do not have enough prospective randomized data. Small studies have shown that body mass and serum albumin levels decrease less with enteral nutrition, and all guidelines actually recommend enteral nutrition over total parenteral nutrition. So in all patients, irrespectively of volume of diarrhea, unless you have, of course, grade 4 or ELOS. To summarize, I think that we can separate lower risk patients with diarrhea from higher risks, and these ones can be treated with lower doses of systemic steroids. We should always include nutrition specialists if we have them, or let's say take care of nutrition, not to forget that is really important. And in those patients, we need to evaluate the treatment response early. I mean, we need to do it in all patients, but in these specifically in order to increase to 2 milligrams per kilo of systemic steroids if needed. And finally, what about liver GvHD? I like to show this case because I remember that I've learned a lot from this one as well. And it was a female patient who had a high-risk AML and went an unrelated transplant, and then had actually elevation of liver enzymes around day 30, but not only bilirubin, but also transaminase. And it was completely strange because she didn't have any skin GvHD and she didn't have any intestinal GvHD. And as I showed you in the first table, the incidence of only liver GvHD or prevalence between GvHD patients is only 4%. So extremely rare to have a liver GvHD in this case. But there were no drug toxicities. She had no criteria for VIOD. We did viral serology to viral hepatitis, and everything was negative. And of course, in that case, we did biopsy, which because the situation was not clear, and biopsy actually showed histopathology consistent with GvHD, and therefore we started steroids, but steroids did not work. And we didn't know what to do, and wanted to do an ECP. And then at the time of ECP, the policy required the DNA, so the PCR again, not just the serology. And in that case, hepatitis C came positive. So we did a track down to the donor and search, but didn't find the reason for that, the family as well. But actually, that was the reason. And the point actually here is that histopathology in liver GvHD is not specific either. We know that acute GvHD typically presents as cholestatic lesion and almost always will be with skin and intestine GvHD. So this should have been, let's say, taken account in this case. We do see the hepatitic variant where we have only elevation of transaminase without other signs of GvHD. But this is something that we will usually see with the taper off immunosuppression or donor lymphocyte infusions. And of course, some of the early signs of jaundice can be due to viruses, drug-induced injury, VOD, and sepsis, but that all is very clear. And then when a question is if we should perform biopsy in liver GvHD, well, actually, well, probably not always, because liver GvHD is going to be together with skin and intestinal GvHD. It's going to be clear. In cases like this, probably yes, but there's no absolute histopathological criteria. So this is what we have to take into account. And we should very well know all differential diagnosis, presentation, and timing of all these complications that can be in differential diagnosis of, let's say, alteration of liver enzymes. And also to be noted that prophylaxis with ursodiol has greatly altered the presentation and does not have patients do not have those higher bilirubin levels like they did before. So liver GvHD is definitely diagnosis of exclusion without absolute histopathological criteria. We should think of viral causes, and as in other viruses in post-transplant setting, there should always be a PCR and not a serology. Biopsy might be essential in some cases, but even with biopsy, the histopathology is not going to always be confirmatory. That's the hard life of a transplant physician. When it comes to treatment of liver GvHD, well, typically it's always, let's say, high-risk patients because it's always together with higher grades of acute GvHD with skin and intestinal GvHD. These patients will always need, let's say, high dosages of steroids, but there is this hepatitic variant, which I mentioned earlier, which I think we all know that responds well to reintroduction of immunosuppression or to steroids as well, the one that happens after DLI and the one that happens as a sole presentation of liver GvHD. Also 80% of these patients respond to treatment usually with steroids and reintroduction of calcineurin. So all this, the sole presentation and the thing that we do not have to act so aggressively, and the thing that we use steroids and calcineurin inhibitors often actually, I would say, explains the fact that in new NIH classification, actually this hepatitic variant is a form of chronic GvHD, so an unclassified chronic GvHD. In these cases, we can probably wait until significant increases in transaminase, because as sharply as it goes up, it goes down once we introduce treatment as well. So as I said, this post-DLI or taper of liver GvHD is considered to be an undefined other chronic GvHD in the according to the NIH diagnostic criteria. So in general, well, I will not maybe repeat it all, but we are relying still a lot on endoscopy and histology, but in acute GvHD, unlike in chronic, let's say that we it's very important to have some clinical experience to manage and diagnose acute GvHD. The most accurate approach for gut would be to do the upper and lower endoscopy at the same time if you want to get this histology positive. Between patients, we can find different scenarios. So we should personalize the management in terms of having upper GI GvHD, which can be treated with oral therapy, lower risk gut GvHD, which can be treated with low-dose systemic steroids. let's say maybe a special entity here is this hepatic GvHD, which responds well to systemic steroids and calcineurin inhibitors. Now I move on to the individualist approach. This is like, let's say, the advanced scenario in case we have it available, so risk-adapted treatment. Over the time, we have had many years of different clinical staging, and of course, to have a risk stratified management, we have to classify GvHD well to know which is the risk and which is the clinical score of GvHD. Thankfully, today we have, and thanks to the MAGIC or the Mount Sinai acute GvHD consortium, which include many transplant centers, we have this MAGIC criteria for grading of acute GvHD, which are accepted clinically and in clinical studies, and which standardize this quantification of symptoms and staging and grading. Once we have graded acute GvHD, we have the guidelines EBMT has issued through Transplant-complications Working Party and updated them. And the confirmatory to what I've said before, decision to start the treatment on expert opinions is based on clinical science because biopsies are often not specific. And then if we have grade 1 acute GvHD, we add topical treatment and continue or restart prophylactic immunosuppression. This is because more infections are happen if grade 1 is is treated with systemic steroids, and there is no advantage in development of grade 3 to 4 acute GvHD. So we have randomized data that proves that. When it comes to grade 2 to 4 acute GvHD, as I said before, it's 2 milligrams per kilo, with no proof that higher dosages will work better or giving another agent together with steroids, so the golden standard, and non-absorbable oral steroids can be given in addition because we have good enough evidence for gut GvHD. So can we then stratify further these patients? Well, I've mentioned it already. There are different risk scores. There's the Minnesota risk score, which actually by the grading and staging of GvHD can stratify patients into high and standard risk patients. And this can actually identify patients at risk for steroid refractory GvHD for higher non-relapse mortality. And this has been validated and today is used in studies as well. And that this staging makes sense has the confirmation also in the randomized data that actually confirmed that some of the patients, and that's the typical patient that I've mentioned earlier, so a patient with 2A acute GvHD with upper GI symptoms, less than 1 liter of diarrhea a day, less than 50% of rash, and without a hepatic involvement can be treated with 1 milligram per kilo without increasing the likelihood of requiring secondary immunosuppressive treatment. What about biomarkers? Well, the MAGIC didn't only do the standardization of staging. They also found two good biomarkers, REG3A and ST2, and then made it into an algorithm. And the MAGIC algorithm probability combines them two into a single value to generate patient probability of non-relapse mortality. So it's a, let's say, a liquid biopsy, but commercially available or not, I'm not sure. In Europe, it's probably not very much used. But it's actually more accurate than changing clinical symptoms, and it can be done at prior to onset of acute GvHD. So at day 7 after transplant, it predicts development of severe acute GvHD and development of steroid refractory acute GvHD, predicts non-relapse mortality, and predicts overall survival. And then it can be done at the onset of symptoms of acute GvHD. Well, it can be prognostic of overall survival, non-relapse mortality, and even stratified patients into three different categories, which each has instinct non-relapse mortality. So it seems that it's very useful. However, it's not readily available in the standard practice. There are even some other additional biomarkers that are being assessed as amphiregulin, which is also associated with GvHD risk, which can then further refine the Minnesota risk score and identifies patients with a lower likelihood of response to therapy. So how would then individualized treatment to biomarker adapted would look like? So low risk patients and then standard and then high risk patients. So Minnesota standard risk or A1 would be the low risk patients, and Minnesota high risk and AA3 would be the high risk patients. And these are the patients that I mentioned at the beginning. So let's say overtreated patients and undertreated patients, because we have proof that those low-risk patients, and this is phase 2 trial of sirolimus versus prednisone, exactly this group of patients most likely was benefited actually. This group of patients benefited from sirolimus, which means that this group of patients most likely could benefit from steroid-free approach, and this is what we actually all want, to get rid of steroids, while high-risk patients are the ones who have poor response, high non-relapse mortality, and worse overall survival, and these are the patients that should probably be included into clinical trials upfront. Steroid refractory acute GvHD, well, we have good definitions thanks to the NIH EBMT and CIBMTR task force that was led by Helene Schumans. And I always recommend this paper because it nicely summarizes all definitions and makes them more clear. So we know what is steroid refractory acute GvHD. Sometimes you always wait, well, let's give it one more day, but what definition is progression of acute GvHD within 3 to 5 days, or failure to improve in 5 to 7 days of treatment, or incomplete response after more than 28 days. This 20 days is always tricky because who can wait for 28 days in acute GvHD to act? So in some studies, it will be after 14 days of therapy or use of additional immunosuppressive agent. But besides steroid refractoriness, I think what is also important to mention is, of course, steroid dependence, which I will mention later on. But what about steroid intolerance? How many of patients have to get off steroids because they're intolerant to steroids? This is a fair number of patients, I would say. Luckily for steroid refractory patients today, we have ruxolitinib. We know that it was approved based on REACH2 study, and the drug got an EMA approval, so it's available not only in the US, but for us as well. And of course, as it happens with all successful drugs, it is being tried in the first line as well, but we do not know the results, most of the results still. What is the problem in ruxolitinib? Well, one problem is that most of these patients still have partial response. That's a problem because, of course, we want patients to get rid of the treatments and not to have to add on something else. And the other problem are the most common adverse events, which are cytopenias, higher rates of infections, and where we, although today, after several years of using ruxolitinib, we hesitate less and we are used to managing patients with cytopenias and infections. But sometimes we do think when we need to introduce ruxolitinib if patient is cytopenic or had some history of previous severe infection. What is the definition of ruxolitinib refractory acute GvHD? We know that most patients will respond in the first 2 weeks. Therefore, the group of experts led by Professor Moti has proposed the definition of ruxolitinib refractory patients, so the ones that progress in 5 to 10 days or do not improve after 14 days of treatment, or lose response at any time. And which brings me back to that 28 and 14 day as an endpoint in clinical trials. Already 10 years ago, we had this hematological study that showed that complete or very good partial response at day 28 is an appropriate short-term primary endpoint. However, I did mention that it's actually hard to wait for 28 days in acute GvHD. And more recently, we have seen data that evaluating responses at day 14 can work as good as day 28. This is again a MAGIC study, and even when combined with biomarkers, it gives superior risk stratification to day 28. Finally, The patient that I didn't show, and that is the high risk, is the patient that develops GvHD during immunosuppressive treatment. So with everything, nausea and rash and diarrhea with more than 1 liter. So a high risk acute GvHD where the treatment is initiated. So with oral steroids and 2 milligrams per kilo. And when we have a complete remission, but then a patient that flares with every taper of steroids and then improves and then flares again. So a patient which we considered a steroid-dependent patient start a second line ruxolitinib, and again have this same scenario that every time we decrease immunosuppression, we have a flare of acute GvHD. The definition is there as well, and the steroid-dependent acute GvHD will happen in 1/3 of patients with acute GvHD, which is pretty high. And actually, why I wanted to show this one, because to highlight this scenario of everything what we have to do in acute GvHD patients. So before we get to this can see, but so before getting to ruxolitinib, we have to be sure to provide very good supportive care, and I have mentioned it. So good caloric intake, protein intake, prevention of infections, vitamin D, physical exercise. All these parts are very important to get the best recovery of a patient if the immunosuppression works. If it doesn't work, it's time for second line. But if the second line doesn't work, and data have shown that it's highly unlikely that we didn't achieve the complete immunosuppression. But it's not always about immunosuppression. They're also contributors to, let's say, worsened clinical presentation of acute GvHD. There are things not related to GvHD as malabsorption, drug side effects, infections, which I mentioned at the beginning, but also tissue damage related to dysbiosis and enterocyte loss. Which actually means that this is something to be worked on instead of adding on the third line of immunosuppression. I will just go quickly through my last few slides just to mention the importance of dysbiosis, because I'm sure that you all know about it. We have data that this is an important contributor to acute GvHD and all the outcomes. We also have data on manipulation of dysbiosis with fecal microbiota transplantation as a third or more lines of treatment. We have some retrospective data on FMT, which are summarized here, and some good responses. And we even have some prospective data of phase 2, where it seems to work in approximately half of the patients that did not respond to previous treatments. We also have a phase 3 that I think has just completed inclusion of patients, and we might see these results. And these are ruxolitinib refractory and steroid refractory patients in the future to see if this hypothesis will work. There are two more things. Well, dysbiosis seems to be dependent on interleukin 22, and this contributes to steroid-resistant gut GvHD in mice. And also, human steroid-resistant GvHD is characterized by tissue response to damage and macrophages accumulation and not T-cell proliferation. So as I said, we've achieved the complete T-cell immunosuppression, but there is something else. And also there are some proofs that interleukin 22 can support intestinal mucosa and stimulate the epithelial cells to regenerate. There's a phase 2 trial of EL22 with systemic steroids as initial treatment for acute GvHD, where response of 80% at day 28 was seen. It seems that EL22 induces epithelial production also of antimicrobial peptides, which leads to the fact that responders have higher microbial diversity. So it all works together, the enterocyte recovery and microbiota recovery together. So In summary, I would say that contemporary initial treatment of acute GvHD today, with all we know, and potentially with the use of biomarkers, could be an individualized risk stratified approach. Some of the low-risk patients, if we define them by this approach, could be good for steroid-sparing approaches. Ruxolitinib is definitely today becoming a standard second line, and some of the patients, of course, ruxolitinib refractory patients have only the option to be involved in clinical trials, but maybe we should start to looking at endpoint at day 14 instead of day 28. And approaches to tissue repair and dysbiosis might be appropriate in those steroid refractory and steroid dependent GvHD. And the questions which still let's say stay to be addressed in acute GvHD, and this could be points for discussion as well, is this use of biomarkers, steroid-free approach, nutrition, partial remissions with the drugs that we have available and how to improve it. Is it tissue repair and dysbiosis? And of course, how to improve the quality of life of our patients. That's it. Thank you.
Thank you so much, Zineda, for this excellent review, and we are perfectly on time, so we have time for a few questions.
Sina, you've spoken about biopsies for the GI and upper versus lower, and sometimes upper and lower help getting a better diagnosis, even if not by the histology itself. Histological findings sometimes are more difficult, but at least looking at the whole mucosa, right? If I understood correctly. One additional point would be, because we're quite prone on biopsying. Unfortunately, we have good support from our colleagues at the hospital, and we do believe that recurrence biopsies are very important. And many times, at least in some cases, we seem to see that diagnosis just changes. You cannot assume if at the beginning was a GvHD that then it's not something else. What do you think about how much can we torture the patients? How often do we do biopsies of these organs and in particular our gut, but also even liver? How would you manage that?
I completely agree with you because, I mean, as we've said, and we all, I think, agree, when we start the treatment, we usually start it based on clinical decision. And this first biopsy for our clinical, let's say, judgment is not so important. But every time afterwards, when there is, let's say, worsening of symptoms, we are not sure what's happening. It could be infection, it could be any of these compounding factors as well. And I think it's really crucial to redo it. And if it works, it's always, I think it's about multidisciplinary management of these patients, and that you have a dedicated person, if you can, a skillful gastroenterologist who always does it and always sees it and does it for you quickly and can give you an answer quickly. So I would say yes. I mean, I would be prone to doing it more than less. And of course, the idea is not to torture the patient, but on the other hand, sometimes this is really crucial for clinical judgment, because introducing new line of immunosuppression can be, in this case, fatal even. So I would agree.
I will make the obvious question. Outside of a clinical trial, what is your preference nowadays after ruxolitinib?
After ruxolitinib, I have lots of experience with ECP. So ECP is something that we still use in acute GvHD. And we have some, I would say, good results. And ECP is always, I like ECP because it works well in patients, I mean, who are very severely immunocompromised. But also, What we are trying to do is FMT as well. So we are trying to do that. So outside, of course, the. I don't know, what is your experience? Do you do FMT at all, or?
We do not. Any experience here? And actually, ECP is not a very good option for us, at least in our experience. So basically, I guess we manage it also very organ-oriented, isn't it?
Yes. Yeah. Yeah.
And what about making the decision? At what time point, considering the studies you have mentioned, should we wait until day 28, or actually maybe too much for some patients? Should we skip and change on day 14?
Yes,
What's your opinion
I
about
think
it?
this is where probably where the future development is going to be, to move it to day 14, because in acute GvHD, well, 28 days is really, especially with proof that day 14 well, acts similarly as a prediction. So I would say definitely, well, when you introduce ECP, you need several weeks to that it acts. So for that kind of even more for that kind of treatment.
And MSCs, because I mean, I don't know, it depends on availability per center, but they now cards are the most common, but they continue to be the second common, and for many years they were the commonest advanced therapy to be used in GvHD.
I'm just saying for what is available in my center, but MSTs are, yes, that's something that I would use if I had them. But we are actually starting some program of producing them. So so maybe yes, in the future. By the way, we need to do a study on MSC.
What is your standard approach, Rafa, after ruxolitinib?
We do produce MSCs locally, so we tend to be ECP definitely is there. We got a very big extracorporeal photopheresis program, and that's something that is accessible. But it's also true that it's getting so crowded with all the lung transplants and with all the solid organ transplants that it's becoming very difficult even to squeeze new patients in. But ECP, I still post ruxolitinib, still that preserving immune function and avoiding other side effects and in these complex patients is a priority. So ECP and MSCs we use quite a lot. And as you know, and one of the things that Sina was making reference to, a proposal of a study within the ABMT, within the working party, to look specifically at the efficacy of the results of MSCs in patients who failed ruxolitinib, because right now we have a lot of evidence in patients who are refractory to corticosteroids, but not refractory to corticosteroids and ruxolitinib. This data that Peter Ball presented at ASH not least last year, the year before, and I don't think it's published, but that was there, and it still showed around 50% response rate, so it's still fairly good for someone who's failed also ruxolitinib. But that's something that we're looking at respectively at the working party, and I think that, and then there's a proposal for a trial that is funded by the Carlos III, by Spanish research system, to do a trial in GvHD, in which some of us, many of us here, will hopefully involve, not so much to look at efficacy of MSCs per se, but to look at potency test that we can use to predict the efficacy of those cells. That's something that is, and I still think that even though no after CARs, they're sort of like the not so interesting, not so sexy any longer, but still do have interest for acute GvHD.
Any more questions?
Great talk. My question is related to the nutrition. When do you use enteral nutrition versus parenteral, or in all cases with severe intestinal GvHD, you recommend use enteral?
Yeah, so only in grade 4 of acute GvHD or signs of cell obstruction, then not. But otherwise, yes. Otherwise, yes. And I was wondering, do you do this? How do you manage the nutrition?
We try to keep the patient on some kind of enteral nutrition, but we used to combine it with total parenteral nutrition together. Mm-hmm. So another, I guess, very practical question is how do you manage steroids? Because actually there are studies suggesting that they are in fact quite toxic for endothelial cells from the gut, avoiding regeneration. But on the other hand, you are scared of tapering the steroids. How do you try to manage this equilibrium between trying to escape them or maintaining the efficacy?
Well, that's the trick question. Well, I always that is always my question that I was previously, and I always remember of. I mean, Professor Zeisser will be today here, right? He always is a very big promoter of very rapid steroids, and then after listening to him many times, I do it much. So he does it not weekly, slowly. So every 3 to 5 days, very rapid taper off. So, well, I don't think that nothing bad happens if you do the taper off more quickly. It doesn't seem to change anything. So I would be now more aggressive in steroid taper. So faster than usually proposed.
Okay, good. So if there are no more questions, we are exactly on time, and we have now 30 minutes for a coffee break, and we will be back at 11:45. Thank you very much, Sina.